I'm Neel Desai. I'm a cornea, cataract, and refractive surgeon in the Tampa Bay market of Florida. And I do everything from complex cornea to cataract or refractive surgery, as well as a focus on ocular surface disease. That actually has become a necessity. I never really went into the cornea arena expecting to be an ocular surface disease passionate specialist, but really it's become a necessity to support the other segments of my practice. It's a bit surprising to me that to this day we're still having this debate between cryopreserved tissue and dehydrated tissues. I think we all inherently and intuitively understand the differences between something that's dehydrated and something that's been freshly cryopreserved. We understand the differences between something that's fresh frozen, like a fresh frozen sirloin, versus a piece of beef jerky. Definitely the flavor, the magic sauce is different. It's been denatured out. The flavor, so to speak, has been denatured out. The tissue workability, the tissue characteristics have also been altered in an intuitive sense. And so the differences, I think, are clear, not only in terms of basic science and the true molecular biology of it. The difference is clear inherently and intuitively from our basic understanding between and the differences between something that's cryopreserved, something that's dehydrated. But I think the key difference that we would see as clinicians, if we're willing to look, is the difference in the quality of healing and the speed of healing. I've had several wow moments. It's hard to pick just one. I've seen everything from taking a melting cornea that was at risk of perforating and being able to turn that around with Procara Plus over the matter of a few weeks and be able to save an eye. I've seen smaller wins and wow moments in taking a patient that had an infectious corneal ulcer, a bacterial corneal ulcer, and enjoying that wow moment in terms of not having to choose between applying a steroid in the presence of an infection and slowing down healing or potentiating the infection versus preventing scar tissue. And I've noticed that the functional outcome after an infectious keratitis is better when I can intervene in the healing process early on. I think the biggest wow moment I've had, though, that really kind of opened my eyes to all of this was a patient who is actually the wife of a ophthalmic industry executive. And she came to me for cataract surgery from out of town, and I had her scheduled for cataract surgery the next day after her consultation and biometry. And one look at her ocular surface kind of made my jaw drop. I saw florid EBMD, superficial keratitis from limbus to limbus, and I realized my hopes of being able to offer this particular patient, a dear friend and industry executive, a premium IOL option would have been limited and certainly contraindicated. And I realized, boy, I can't even do basic cataract surgery for this patient well and expect a good outcome because my biometry was so far off. I saw dropout zones on the topography. Our IOL master and LensStar was showing me 5.5 diopters of astigmatism. I saw irregular islands on the topography. The posterior float was, completely irregular. It just looked like an irregular cornea, and I knew that obtaining biometry for even standard cataract surgery was going to be impossible. So we elected to do things the right way rather than the fast way. And so I did bilateral superficial keratectomies, followed immediately by the placement of a Procara Slim. We placed that for only 3 days, actually 2.5 days. We removed it, and she had complete reepithelialization of her cornea following a superficial keratectomy, basically to 1 millimeter of the limbus. And not only did she have complete reepithelialization, but she had quality healing. There was no haze, no scar. It was like a new eye. And so within a month of allowing the cornea to stabilize, getting her initiated on some topical therapies for ocular surface disease, immunomodulators, etc., we were able to bring her back for repeat biometry and plan her cataract surgery well. So whereas I could not have even achieved a good result or a confident result with basic monofocal IOLs, I was actually able to offer this patient an extended depth of field lens, a Symphony lens, that she would not have been a candidate for before. And she achieved a 20/20 J1 Plus outcome that she knows and I know that we would not have been able to deliver for her or achieve without the help of Procera and its powerful healing mechanisms.